morning, almost afternoon, everyone, and welcome to our webinar. Thanks as we got our tech stuff set up and got people on. We are very, very excited for the second in a three-part webinar series entitled Building Networks for Advocacy and Reproductive Health. If you were on with us for the last webinar, you would have seen some of the really quick logistics that we did before, but just in case you weren't, I just want to go over these so everyone feels really comfortable. If you can go over to the chat box, it's on the bottom right of your screen, and just say hello, good morning, almost afternoon, just so that we make sure that's working and you can hear me. That would be great. All right, and we're going through screens. It's like a roller coaster ride in the morning. That's always fun. And then, secondly, if you can go ahead and you will see there's a small little button that looks like raising your hand. If you can hit that for us right now and go ahead and raise your hand so that we know you have the ability to do that. I'm going to circle it with the mouse on my screen, and it's gray. It's on the side of your panel. And Peter, can you let me know if folks have their hands raised? Awesome. So now, because I have the power, I'm going to lower all of your hands. Bam! Fantastic. So if you ever want to be unmuted, you can go ahead and do that, and we'll try to answer any questions, and we hope that you share your knowledge. You can send any tech support questions, and we've got Peter Fiala here with Wausau, who is great and can help answer those. Other things coming up, if you haven't heard already, put June 5th and 6th on your calendar. Mark that down at the Crown Plaza. We're going to meet in person. And our third upcoming webinar in this series is May 6th, and that's Best Practices in Assessment and Referral. So that being said, my name is Rose. I'm with Kelly Molitke and Peter Fiala here at Wausau, and we are so excited to have Susan LaFlash, who's the Rape Prevention Program Director with the Department of Health, doing this webinar today. So with that being said, I'm going to hand it over to her. Thanks.
Good morning, everybody. So this topic for this webinar was the intersections of advocacy and reproductive health. And as we started this project, we all sort of intuitively knew what those intersections were, but it actually has taken us a while and some conversations to really flesh those out. So part of the setup today will be just sort of an overview of sexual violence in the community, in the world. There's some data, some statistics that we'll go over. The idea being that it really is all around us, and it's really something you don't really know about clients unless you ask them about the people they work with, about the people you work with. And while people with advocacy organizations on, I know you do know about violence in women's lives current, but it's sometimes the history and the historical trauma also that makes sense. We're going to go through that for a bit, talk about some specific intersections, and then we have two guests who are going to be talking about how they have made their programs work in Wausau, and they will be on the last part, probably about the last hour, and describe how their collaboration has worked to provide some holistic health services to women in their area, both around reproductive health and advocacy. So this first slide is from the World Health Organization, which is actually a really good resource for violence against women worldwide, and they come up with some consistently good research and reports and best practices. Over 1/3 of women worldwide have experienced sexual violence and or intimate partner violence, and a little bit more than that accounts for murders of women around the globe being committed by an intimate partner. Rape has been used as a weapon of war throughout history. It is used to control the enemy, and that has been going on again throughout history, as well as within our own history here in the United States, i.e. slavery. Rape as a weapon of war was used heavily during the Revolutionary War as well as the Civil War. Rape is also used as an initiation into a group. And again, this is at many levels. It's often commonly thought of as with gangs, but as we are learning more and more, the military also uses it as an initiation ritual. Fraternities seem to be adopting the practice, and any prominent group or dominant group of any kind oftentimes will use the power of rape as a way to bring members in. So I was going to talk a little bit about the definitions of sexual violence and intimate partner violence that are used by the World Health Organization, where these data came from. And for them, they use a very broad term that it's any sexual act or an attempt to obtain a sexual act that is unwanted. It includes sexual comments or sexual advances, acts of trafficking, or anything that's directed against a person's sexuality that uses coercion. And it can be done by anybody regardless of their relationship with the person. And it can be done anywhere. Intimate partner violence for the World Health Organization is any behavior within an intimate relationship that causes a wide range of effects, including physical, psychological, sexual harm. And this includes, again, not only physical aggression, which seems to be the largest way people screen for trauma and violence, but also psychological abuse, forced intercourse, sexual coercion, and various controlling behaviors such as isolating from friends or financially. Again, in the United States, as we kind of go from global to local, this information now is coming from a CDC venture that began in 2011. It's a random telephone survey called the National Intimate Partner and Sexual Violence Survey. It's a broad enough that they do have state-level data. We're hoping that eventually they'll have enough numbers that they can give us even more local data on a state level, but right now that's not possible. They do ask questions about rape, sexual assault other than rape, intimate partner violence, stalking, and they do a fair array of questions about the impact that that experience has had on the people participating in the survey. So from that survey, you can see the lifetime prevalence of rape for women is 18.3%, and for sexual coercion is 13.0%, and for men it's about sexual coercion, it's about half of that, and for rape obviously much lower. We do find out in this survey, as well as from our own Wisconsin survey, that rape is a crime against the young, although it can happen at any age. Over a quarter of the men were raped prior to the age of 10, and almost a third of the women were raped between the ages of 11 and 17. So this is a crime, an experience that, as we will find later, has lifelong impacts on growth, development, health, you name it. So, again, from the, we call it fondly the NSVIS survey, which is available on the CDC website if you're interested in looking it up for yourself. They do measure stalking. Stalking is not a very well measured item, and it's also something that people don't necessarily talk about. People tend to be a little unsure of what the stalking really is. How NSVIS defines it is that it's a pattern of harassing that causes fear in the victim and or safety concerns. So as you can see, about 3 times as many women as men report stalking in their lifetime. But again, the level is not insignificant for men, and this is one of the reasons this is a little bit in flux right now, is because of the expansion of technology and what does technological stalking look like as opposed to hiding in the bushes or knocking on people's doors, et cetera, et cetera. NSVIS measures intimate partner violence by including both stalking, rape, and physical violence. It also includes control of reproductive or sexual health. So NSVIS actually got the intersections before they did the sample, so that's kind of exciting. The related impact, as you can see here, 29% of women reported that they had some impact from the experience, and almost 10% of men. The impact was measured that they were measuring was any concerns for safety, any symptoms of PTSD, any injury, any need for medical care, and also need for services such as housing, protection, legal advocacy. It includes whether they felt they needed to contact a crisis line, if they missed a day of work or school because of the incidents, or if they contracted an STD or became pregnant. And in this list, it was about 1.7% of women reported becoming pregnant. So of interest to our work on intersections here. In the United States, and again this is all from NSBIS, there are significant health outcomes, and because I'm from the Division of Public Health, that's what I'm going to talk about a lot. What they discovered particularly were these: difficulty sleeping, chronic pain, high blood pressure, activity limitations, asthma, and frequent headaches. And you'll see later that a few of these come up in some other research that's been done around trauma experiences. In Wisconsin, NSBIS found that the lifetime prevalence of rape is 17.7%. I think that's, well, rape and stalking. Rape is 17.7. For women, stalking is 12.7. And for women in Wisconsin, 23% of them reported some sort of related impact. Again, they don't really have any enough numbers for the denominator here to go down to any kind of organizational level or county level to use this information. But I think it's something you could, to get a sort of an idea if you were working in a reproductive health clinic, just to sort of think about approximately 17% of women clients that you see may have a history of some sort of trauma. Just don't say the CDC said it, because they'll deny it. But in Wisconsin, sexual violence other than rape, according to NSBIS, was about 41%, and for men it was almost 24%. And again, you can see for intimate partner violence, 32% for women and 23% for men. So it's predominantly, women are disproportionately affected by violence, sexual violence, and intimate partner violence, but it is not a women's only issue. And while for the groups on the phone, we're predominantly talking about adults, as we saw earlier by the age groups that sexual violence affects, children are very much affected by this, and it should always be considered, and sexual violence against children is relatively high and can have some tremendous outcomes. So please also consider talking to women that you work with about children in their environments or households. So I was talking to you earlier about the other research that's gone on about experiences of childhood, trauma in childhood, and what I was referring to specifically was the Adverse Childhood Experiences Study. This study's been going on for since the 1990s, was when the original study was done in California. Since that point, there's about 21 states that have been able to assess it within their own states, and this is done by adding a set of questions, of 8 questions, to a statewide survey called the Behavior Risk Factor Survey. And what that does is allow us to look at people's trauma history relevant to their current physical health and risk behaviors. So it's quite a rich pool of information. The ACEs, Adverse Childhood Experiences, the questions revolve around physical abuse, sexual abuse, emotional abuse. And then there's a series of questions about household experiences, what environments they grew up in. And those questions relate to whether they're members of the household with mental illness, and that includes suicidal behavior, substance abuse, separation or divorce, violence between adults, and any household member who is incarcerated. So these are some of the, in Wisconsin what we're finding is that, and this is broken down by male and female, in Wisconsin over 60% of adults report one or more ACE, and the ACEs are determined by adults recollecting their childhoods prior to the age of 18. And 17% of women and almost 15% of men report having 4 or more ACEs. And 4 or more ACEs are determined to be sort of the tipping point where negative health and behavior outcomes begin to occur. The ACE information also is available on the Children's Trust Fund website. It's wichildrenstrustfund.org, and you can download the entire report from them as well as the latest update, which is the 2011-2012 data. So first I have to say I did not mean to cut off Douglas, Bayfield, Ashland, and Iron counties at the top there. There's no slight intended. It's just my technological failure in translating this onto a slide. But as you can see, this is the 2011-2012 ACE data, and it shows the prevalence of 4 or more ACEs in Wisconsin. So you can see that they're pretty widely spread. The deepest pink color is counties that had more than 20% of the population reporting 4 or more ACEs. And then going down from there. So again, widespread and occurring in every area of the state. And it's interesting, at the Department of Health, once we got this map, we decided we'd start to look at areas with various other health risks. So we're looking, and we don't have no idea if this is going to be statistically valid or not. We just started looking at it. But we're looking at areas with high teen pregnancy, with high suicide rates, and some other health indicators to see if any of this overlays each other. So we'll keep you posted. The state rate for this also shows that over 25% of residents of Wisconsin have 4+ ACEs. There is a whole slew of national research for those of you that have not been exposed to this before, and international research based on the ACE findings. The interesting part of the ACE is that when they asked these questions, they also had access to all of their medical records, including prescription medications and diagnostic tests, and so there's a huge body of research information on this. And what they have found thus far is that the higher the ACE, the more likely there will be some negative health outcomes in particular, such as, and they follow a trend which I think is interesting. So early initiation of smoking, bronchitis, COPD, and lung disease are all risk factors the higher your ACE score. Suicide, anxiety, depression, asthma, which we saw earlier as a health impact for sexual assault. Health risk, sexual behaviors, multiple partners, early initiation of sex, STDs or STIs and HIV, adolescent pregnancy, and adolescent fatherhood, and then getting back to cardiovascular disease, diabetes, and obesity. Again, going back to, are these coping mechanisms, or are these is there something genetically going on? It sounds like a little bit of both, but we can all recognize the role of coping mechanisms in these outcomes. So now, getting back to who we serve in our organizations, advocacy and reproductive health clinics. We were able to do a little bit, I think from the previous work, we know that all of our clients, or not all of our clients, but there is a probability that many of the clients and the people we serve do have some trauma in their history, whether it's been addressed or not. We did, at DPH, we did a little bit of research into some of the statistical information we get from newly pregnant mothers, and that's called the Pregnancy Risk Assessment and Monitoring Survey. And in that survey, this is a random telephone survey of new mothers based off the birth certificates, and they are just sent a questionnaire. There's actually some pretty heavy follow-up, and they do some oversampling to assure some diversity, economic as well as racial and ethnic. The PRAMS data showed that 7% of the mothers surveyed reported being a victim of physical abuse by a current or former spouse or partner before, during their pregnancy. Now, one of the limitations of a lot of these surveys that are working with particularly new mothers is that they talk only about physical abuse. And they talked about being the common one. I think you probably will, many of you will recognize, at least the family planning folks will, is the have you been hit, slapped, kicked, punched, or something else by a partner. And it's usually just one question, and it's usually done at the initial assessment. So there are some inherent weaknesses under counting in the data that addresses new moms, etc. They also generally focus on current abuse or abuse within the previous year. So that's also another limitation. In that same survey sample, a little more than half of the mothers reported that a healthcare provider had asked them if they had had any experiences of physical abuse. So this is all women in the state, so it's public and private providers of prenatal care. What we discussed when we saw this was that there's no single uniform profile for women who experience violence. You can't tell by looking at somebody what their history of violence in their lives is, and that a violence history should begin to become a normal part of providing care, part of an assessment, as well as paying attention to a safe setting for response and services. Again, advocacy agencies who are on the call understand the importance of that feeling of safety. So I think we can all learn together about that. We did another look at some data we collect on pregnancy outcomes for people that get a service called prenatal care coordination. And we looked at the data reporting of women that were asked the question. Again, it's one question. It's the physical question about hitting, shoving, etc. And we found some interesting that the women, we looked at abused versus non-abused women, people who reported abuse versus those that denied. It was about 19% of women reported some form of abuse. We also found that they were reporting, you can see the differences here, significant differences between women who were abused and not abused, and their reports of prenatal mental illness, postpartum depression, whether their prenatal stress was high or whether their postpartum stress was high. And again, all these are extremely significant for children who are born into these families, as well as for the women who are experiencing the trauma and then childbirth. We also found in a survey of prenatal care coordination providers that there's a fair amount of uncertainty as to how and when to ask the questions. They all had a sense that the one question they were asking wasn't enough, and that it didn't get necessarily at what they wanted to know or should know. But there was also a fair number of people who were just uncomfortable asking the question, not knowing what to do if there was a positive response, whether it was appropriate to ask the question, and again, just how to ask it, how to probe more deeply if someone said, yes, I am being abused or whatever. Trauma history also has a significant impact on labor and delivery, as well as breastfeeding and bonding with the child. So even if it's not happening concurrently with a pregnancy, it is an important issue for a woman's future as she moves on into a reproductive stage of her life or having children. Again, we'll go through these fairly quickly, but the history of being abused also really increases behaviors that put not only the woman but the baby at risk. So here's smoking. Pre-pregnancy, 62% of women who were abused smoked versus 44% not abused. Postpartum, again, still twice as many women who were abused went back to smoking, even if they had quit during the pregnancy. Drinking, again, the same piece, and in public health, we just look at this long term in terms of what impact this is having on that family and the baby's growth and development. So where do these bubbles intersect? Although I realize they aren't bubbles, but where do the gears intersect? As I mentioned before, it is more likely than not that people that are presenting for health care will have some history of trauma in their lives. And if you look at the ACE studies even, it may be something that we all sort of take for granted, such as a divorce in the family. So I think it's important for us to realize that those people react to those things differently, and that they do have an impact on the person that's sitting in front of us. It may be historical, it may be current, both may be happening. They may not know that it's okay, that it has anything to do with health. And even if they're presenting in a traumatic situation for help at an advocacy organization, they may not realize that what happened to them in the past is affecting what's going on now, or that what's going on now is going to have an impact on them in the future. So the purpose of this whole piece was to look at what are their intersections. Let's look at the women who are seeking service, or the men, and what are the needs that both types of organizations can work together on to fill. This information comes from several sources. One is some of you may have participated in some phone conversations we had in December. We had a conversation with the Family Planning Reproductive Health staff and with staff from advocacy agencies. It was an open invitation for anybody to participate. And we did an exercise where people kind of just tossed out the words that they associated with the other specialty area. So many of these words come from that exercise that we did, and that's where the Wordle came from, as you know, on our announcements, etc. Others came from, I did sort of just a random Google of family planning centers in Wisconsin and advocacy agencies just to look to see if there were any additional words that came up also. So we included some of those. So again, family planning clinics, primarily they're associated with women's health, birth control, emergency contraception, STI, HIV testing, screening examinations, and by that I'm talking about ultras, pap smears, and breast exams, mammograms, pregnancy testing, enrollment in healthcare coverage, information, proactive care, referrals, accessible, and youth and adolescent health. For advocacy agencies, the words that most commonly came up either on the phone call or on websites were women, shelters, advocacy, safety, SANE or sexual assault nurse examiner programs, therapy, counseling, protection, legal information and counseling, 24/7 availability, housing, and youth and adolescent health, which I thought was interesting. So we have a natural tie-in there for communities. So client needs, then I tried to sort of pull back and look at, and I'd like people's input, just think about this for yourself and what you would define. These are by no means exhaustive lists, either on the last slide or this one. But if you start to look at what client needs are, and I was thinking of it as a client that could be seen in either organization type of organization for various purposes. And these were a few that I came up with. And the purpose of this in the next slide is just to really be thinking about who meets those needs and in what way. Because I think in some ways family planning reproductive health clinics meet many of them and advocacy meets many of them, but perhaps coming from a different framework. And the discussion at some point may be around how we bring those frameworks together so they're seamless for the client, for the woman or man involved. So client needs are oftentimes acute medical needs, reproductive health counseling or treatment, trauma history, current trauma, mental health needs, pregnancy, STI, HIV testing, reproductive coercion, safety, and healthcare coverage. And putting on healthcare coverage, I think we all have roles now in getting people into a healthcare system that is, we really need to be grabbing onto this opportunity now, and not just the traditional ones of Medicare and Medicaid, but also Affordable Care Act, and even our local or regional healthcare systems that are more in tune to the Affordable Care Act at this point in time and the requirements for that, which does cover all of these, is a required coverage for all of these needs. And then looking at what the work we've been doing with WCASA, or what WCASA has been doing, is looking at the community health needs, or the community needs. And again, what we're finding is that communities are in need of information, training, anything else you can think of around healthy sexuality, empowerment of women, not only to be more in control of their own health, as well as their traumas, their trauma history, addressing them, knowing their value. Preventive health care, prevention of adverse childhood experiences, and there actually is a bit of work going on around that, so it's good to sort of explore your community and find out what's happening with early childhood, etc. Healthy births, safe neighborhoods, honor of culture, healthy parents, and skillful parents. So the work that both of our agencies do, advocacy as well as family planning, reproductive health, is to create healthy women that's then can translate, if that's the choice, into healthy parents and skillful parents. So that is sort of the presentation of how these two different professions intersect around reproductive health, long-term health needs of clients, and trauma experiences and acute experiences of trauma, and how we can begin a conversation about, within a community, how we can take that to the next level. And I think the interesting part of this objective that we are working on with HCET and WCASA and Division of Public Health is that we do understand it's community-based. We know that this has to take place within the context of a community. We also know that it needs some effort to make it sort of an institutional practice on the part of advocacy agencies and family planning clinics to make that happen continuously. But we also know that there are a number of commonalities that can happen and can really be improved for communities and for women in the community. And that's where we want this discussion to begin and to move along. And to help with that, we have a couple people who are really going to be able to talk about how they did that in their community of Wausau. And that will be our next speakers are Jane Graham Jennings, and she's with the Women's Community, a sexual domestic violence agency in Wausau. And Frances Irwin is from the Family Planning Health Services, a reproductive health clinic in Wausau. And they have been collaborating for quite some time. They are the two sort of point people for this collaboration. And we asked if they could just come and talk to you about how this got started, what were the commonalities they saw that they could collaborate on or be synergistic with the other agency for women. And again, this doesn't always go smoothly, so the barriers, challenges, as well as successes, and how they sustained it. So we're all set now with sound, right? Okay. So I'm going to turn it over to Jane and Frances, and they have been working together on this presentation. So,
hello, it's Jane. Can you hear me?
Hi, Jane. I can hear you. This is Frances. Can you hear me?
I can.
Fantastic.
Great.
Let's assume that's a success for everyone.
Can you go ahead and do a sound check for me?
Hello?
If you can please say something else and go ahead and check the sound.
All right, so you're looking for a sound check. So So this is Frances Irwin. I'm here today at Family Planning Health Services, our new Lake Delton location at 1425 Wisconsin Dells Parkway, Suite 7. We're very excited about this new location. Do you have what you need, or do you need me to keep going?
Tell them that.
All right, you ladies are perfect, and we're good to go.
Okay. All right, Jane, do you want to talk a little bit about the women's community and what in your role there to get us kind of kicked off?
Sure, I can. I just want to make sure you can hear me as well because I can't hear anyone but Frances.
Yes, I can. Yeah. Tell Jane and Frances the sound is both good. The sound is good for both Janie and Frances.
Did you hear that, Jane?
No.
They've got us. They've got us
Okay.
out there.
Well, then I will go ahead and get started. I'm Jane Graham Jennings, the Executive Director of the Women's Community. We're a domestic violence, sexual assault advocacy agency located in Wausau. We've been in the community since 1978 is when we started providing the services and have been providing services primarily to Marathon County for victims of domestic violence, sexual assault, and stalking. I have been working with the women's community for 18 years and have been director for almost 14.
And I'm Frances Irwin. I'm with Family Planning Health Services. Family Planning Health Services is a maternal and child health agency. It's a not-for-profit that provides WIC services in Langlade, Lincoln, and Marathon counties, and provide reproductive health services in Adams, Juneau, Lincoln, Langlade, Marathon, Portage, Taylor, and now Sauk County. And we also have a partnership with the City of Milwaukee Health Department, providing some limited services embedded with their agencies. In the reproductive health program, we provide preventative reproductive health services and information. So annual exams, pap smear, sexually transmitted infection testing, treatment, pregnancy testing, and a wide range of reversible birth control options, whether they be what we refer to as LARCs, or long-acting reversible contraceptives, or what people classically think of as birth control being, you know, pills and condoms and things like that. At Family Planning Health Services, my title is Outreach Coordinator, and basically my job is the door, to make sure that, you know, our agency is welcoming and available to those who need us, and to work with folks who are having a little bit of trouble getting through the door to find out what it is that we can do to help them get here. As Jane mentioned, the women's community has a long history in Marathon County, as does Family Planning Health Services. Our agency started in 1973. And in that regard, I think our roots, as agencies, our roots and our goals are very similar. We both have a long history of serving our community. We both kind of started a little bit underground. You know, I think Jane can probably talk better than I can about some of the challenges that we face. Just getting people to accept our services is something that's important in the community. So.
Yeah, I think that was one of the things we were talking about in preparing for this discussion, was kind of a lot of what we deal with, both family planning as well as advocacy services, is historically taboo, and it's not stuff you really want to talk about, and in particular women's health. And the other thing I think for advocacy is that often the link between long-term health and issues of violence against women wasn't really seen. For example, several years ago when there was a health report done in Marathon County, and I noticed that intimate partner violence or domestic violence never appeared on that health survey as a risk to health in the community. And when I asked about that, the response I was given was because domestic violence is an acute situation and doesn't have anything to do with long-term impacts of health in a community. So I have since argued that point, and it now shows up on all of the health surveys because it absolutely is a health factor, but it's just one of those things that when we're not thinking about it or people aren't discussing it, it falls off the radar. And so I think in terms of family planning issues and domestic violence, sexual assault issues, we've been kind of underground, and we're trying to bring all of that out of the darkness.
And that's something that both of our agencies have been very committed to, under current leadership and for family planning health services under our most recent executive director. Lon Newman, if you've ever met him, his line was always, we are proud providers to the empowered. And so both of our agencies are very proud of the services that we provide. We work very hard to ensure that we are providing top-notch services, whether in our individual fields, and that the clients we see feel empowered to make the choices that are best for them in their situation. We both trust our clients to know what is best for them, and as a result, we are able to provide our services with a high degree of excellence. So, so I think having that shared background within the community and having that shared commitment to empowerment and empowerment of the individual has put us in a good position to partner together.
And so, in really practical terms for people who are saying, well, what partnerships did you do? We've done a couple of things, but our first partnership was really around access for easy access for women who had, in particular, sexual assault victims, but any women who had unprotected intercourse that was concerned about being pregnant. So a number of years ago, I think it was 2004, is that right, Frances, about 2004?
Yeah, that's when we first got the money.
Actually, Lon Newman approached me and said, would you be interested in this partnership, in that they would supply us, we would have the actual easy pill packs here on site, and they would be accessible to women who would come to us because we were a 24-hour agency, that we would have that available. We would contact family planning health practitioner who would do some surveys and some interviewing with the woman, and then if all of those things were in place, the advocate at the women's community would actually be the person who would hand the pack with the pill in it to the woman, and that's kind of where our relationship started.
You can take this. Okay, I still want to hear. You can take it.
So, and that's, I think, a really important point where we started was with emergency contraception. In 2004, there were a lot of barriers for victims of for women in general, but in particular for victims of sexual assault, to access emergency contraception in a timely manner. As I'm sure you're familiar with, emergency contraception is a time-sensitive medication. To be effective, it needs to be taken within the first to be most effective, it needs to be taken within the first 72 hours or 3 days. At that point, it's 80% effective. If you wait till 5 days later or 120 hours later, it's now only 50% effective. Better than nothing, not as good as 50%. So we wanted to make sure that that everybody had access to that medication in a timely manner. In 2004, the medication was sort of still relatively new to our medical community. There were providers who were requiring a full pelvic exam in order before they would dispense the medication. Hospitals were not required to have the medication on site. It has since changed with compassionate care for rape victims being passed, that emergency contraception is now required to be available for victims in the ER. But unfortunately, that wasn't a standard practice when we started talking in 2004. Furthermore, it wasn't until pretty recently that emergency contraception was included in the formulary of medications that would be covered by the SAFE Fund or the Crime Victims Compensation Fund. So what we're able to do at Family Planning Health Services is we are able to assess a patient's financial situation to see if they qualify for state programs or to see if we maybe have some programs or partnerships available so that people are able to access emergency contraception at low or no cost. So the barriers, as far as emergency contraception, some of those barriers have changed over time, but some of them, particularly cost, can still exist. So we try to work closely to make sure that that people are able to take advantage of that full range of access. And for us on our side, we know that our patients experience domestic violence and sexual assault. You know, we are mandatory reporters for minors, so if we do suspect sexual assault or sexual abuse or any abuse of minors, we do report that and address it that way. But we also know that there are people over the age of 18 who have these experiences who aren't required to report, and a lot of times just getting in the door of an advocacy agency is scary. So this is an opportunity for us to have a soft or a warm handoff with our local community partners, so that people who are needing access to services can kind of test drive them, so to speak. You know, walk in, see a friendly face, get what they need, and then and find out that it's not as scary. So so I know that for our providers, having the relationship with the women's community has been very helpful, because then when things do arise, we know who to call, and we know that when we call, the experience that our patients are going to have is going to be, contextually speaking, a good one. So so one of the first things after we sort of identified the problem we did was we kind of took an inventory of what resources each agency had to contribute to solving the problem. So Jane's mentioned a couple of things. Family Planning Health Services has access to emergency contraception. We have access to reproductive health providers. We have access to medical research that tells us the best way in which we can provide these services with the greatest efficiency. The women's community has advocates to provide services to victims and survivors, and they also have a location that is secure and available 24 hours a day, 365 days a year. So so for both of us, when we sat down and we started defining what the need was and what the resources that were available on each side, it became very clear to us that our clients stood to gain through this partnership. So we developed a memorandum of understanding between both agencies that really outlined who was going to do what, how it was going to be done, and what sort of follow-up could be expected on either side as the partnership went forward. The next sort of thing that, after we kind of defined and started outlining these things, we kind of had to evaluate where each agency had to evaluate where they were and whether or not they were ready for change. And I think the key pieces that there were three key pieces for evaluation. One was the leadership prepared for change. I think clearly in our case, you can hear from Jane's remarks that both agencies at the executive level were committed to working together to find a way to serve our clients in the best way possible. Then we had to evaluate whether or not our staff was ready for the change to make a partnership, to work together. You know, and then we also had to sort of take a look at how our agencies worked in these areas to determine what barriers there were to care, why they existed, and what could be removed or minimized. In terms of, you know, staff preparedness for change, you know, once that was assessed, we could figure out we were lucky. Our leadership was on board. But, you know, in cases where, you know, maybe leadership has questions, it's important to develop sort of a plan that can be presented And the MOU, the Memorandum of Understanding we have, really sort of did that for us. And then in terms of staff preparedness for change, a lot of times staff wants to know, what do I need to do? Because both the staff at the women's community and the staff at Family Planning Health Services, they just generally speaking are amazing human beings who are committed to doing the best job that they can for every single person that they interact with. And knowing, and so a lot of times when you sit down with them and you ask them, you know, can we do something, the only reason that they're hesitant is because they want to be able to do it well. And they want to be able to do it competently, and they want to make sure that that they're doing the best every single time. So so one of the key barriers to care that we identified is that Family Planning Health Services has some specific rules about confidentiality, and the women's community has some very specific rules about confidentiality, and sometimes they come into conflict with each other. So, so through many conversations, we were able to work out a system for how we would be able to maintain each system and still allow the client to get the services that she needed and desired. So, so once that evaluation was done, we developed a process for meeting the needs. We created a system for communicating feedback. We created a training plan. We talked about marketing. With this particular thing, in 2004, emergency contraception was a pretty new concept, and people had real ideas about what it was and what it meant. So we wanted to make sure internally that everybody involved knew what emergency contraception was and how it worked. And then we had to also talk about externally, outside of our agencies, how were we going to talk about this partnership. And so we worked, you know, Jane came down to Madison with us one time, and we did a breakfast for community advocates and policymakers and folks across the state who were wonderful enough to join us at, you know, 8 in the morning in Madison to have breakfast and to talk about emergency contraception. We tested the process a couple of times, ran through what worked, what didn't work, and then made adjustments to that plan so that the first time a patient went or a client went through it, they had the best chance at a successful outcome as possible. Trained the staff, implemented the program, and adjusted the process. And we've adjusted the process actually quite a bit over time to meet the needs of both agencies and primarily the clients. So in particular, I think what has been really key for making our relationship work is the process for communicating feedback. It's clearly defined within both agencies. If something comes up with this, who should be contacted and how. And primarily, you know, we've used phone calls, occasionally emails, but mostly phone calls because HIPAA is king in the healthcare world as well, and confidentiality is king in both of our worlds. So, so communicating has been a huge piece of making the partnership work in terms of both getting it off the ground, maintaining it, and taking it to the next level. Jane, did you have anything to sort of add about that development process and how we got going?
What's always key in any kind of partnership is you also have to have, you know, communication is essential, but so is patience, because you're going to adjust things as they go along, and you know, there's going to be some things that don't work out. So, for example, when we first started, we didn't have access to a nurse 24 hours a day. So even though we were a 24-hour operation, we had to figure out how to kind of make that work, and that's adjusted and changed over time, and now it is 24 hours. If we have someone who comes in at 2 in the morning and needs access to emergency contraception, we can get that to them through the on-call nurse. So, you know, that's something that's just changed over time, but you have to have patience with any partnership, with the, you know, full faith that everybody's trying to do what's in the best interest of the clients that you're serving, and that you're all trying to make it work together. And so to that end, the other thing that we are just currently embarking on is a telehealth network that we will have on-site computer, actually, where clients that are here at the women's community, or even if they're not residents of our shelter, but clients that we're serving who are comfortable at this agency, can come and access a nurse through a computer system that we have a meeting room, that we have a computer hooked up from that family planning actually installed, that they'll be able to access a nurse through the telehealth, so they don't have to make more than one trip. So if they're living in shelter, they can just come into that room and talk with a health practitioner through the computer network, and that is completely confidential, so that if they want an advocate in the room, we could be, but more than likely we're not going to be in the room. We'll just set up the time for them to talk with that nurse through the computer, and then as that moves forward, depending on what the needs are of the client, we may have things housed here on site that we can then pass on, not unlike the emergency contraception, to the clients that we're serving, so that they have their needs met while they're here. And that is, again, brand new, and we're just getting that kicked off, but we're pretty excited about that as well. Again, just trying to find ways that we can reduce any barriers for, in particular women, but any victim that we're working with, preventing any barriers that exist for them getting full access to health care.
And at Family Planning Health Services, we're incredibly excited about the opportunity that the telehealth partnership with the women's community provides, because we do see people who are in need of an advocate, and sometimes, you know, getting them, you know, our facilities are literally 5 minutes apart by car, you know, but for some folks, just leaving where they feel safe is too much. So making that so for us to be able to set someone up with access to an advocate via video conference through the telehealth unit, really we think does a couple of things. One, it expedites the process, because we know that the longer people wait to follow up on referrals, the less likely they are to do so. Two, it allows us to it just allows us to give our patients more, and we don't have to become experts in providing advocacy services, because the women's community are experts, and so we don't have to, you know, we don't have to come up with that, and we know that, you know, for example, if we see someone who we refer through telehealth to the women's community, and the women's community has a conversation with them, and then they seek shelter at the women's community, if they need some, you know, some follow-up appointments with us, there's quite a bit that we can do via telehealth without the patient having to present in clinic. You know, if they need follow-up on test results, if they just need to check in to let us know how their current method is working, these are all things that are very easily done via telehealth, so that they can continue to have access to our services in a way that is comfortable for them, perhaps reduces barriers related to transportation, or other, you know, other things that just come up, you know, fairly routinely, and it also allows us an opportunity to really make the most of that piece of the Affordable Care Act that in the Women's Health Guidelines, where now services for sexual assault and domestic violences are required to be covered by insurance companies. So we can make sure that, you know, if we assess someone who has a need, we have a good immediate connection to our partners for making sure that clients who accept services, again, this is all client driven. If a client says, you know, no, I don't want emergency contraception, no, I don't want to talk to the women's community, no, I don't want, that's okay. You know, it's okay. It's a thing that happens, and they have that right. So so we want to so we're sensitive to that as well. But when it works, you know, we're going to get it to a point where it works pretty seamlessly for them. And being able to work out the referral process for how that makes a client's life better is very exciting I think for both of us, and really gives us an opportunity to improve our services.
Absolutely.
So, in conclusion, I think we've both discovered that this is a really good thing for both of our agencies. Our clients absolutely benefit. It reduces emotional stress. It reduces stress on the system because the partnership exists, and it's better for our community too, because in addition to greater access, we're also establishing we have established a really formal relationship with each other. I always tell people that the work that I do is really important, which is why if I'm hit by a bus, I want to make sure that someone else is able to pick up my duties and go forward and be successful from day one. And by formalizing our relationship and putting these pieces in place, I'm confident that no matter what happens, Family Planning Health Services and the women's community will continue to work together to serve our clients and our community going forward.
I think the other thing that's really important from the perspective of people seeking services is it shows that there is a partnership there, and oftentimes, if we're fortunate enough that we find a client that comes through and we've done our job and they trust us enough, and then they see that we trust family planning, there's going to be an easier trust developed there, especially when we're dealing and trying to address reproductive coercion with our clients around issues when they're trying to get birth control but their abusive partner is prohibiting that, and what are ways that they can still protect themselves from unwanted pregnancies without their partner knowing, and some of those really frightening nuances of our clients, but that we could kind of have that relationship with family planning, and it makes it a little bit easier for them than to trust that there's another agency that's not going to judge them but is going to be there to help them figure out how to survive.
All right. I want to thank both of you for taking the time to talk through that, and that's really fantastic. I also want to open it up for some questions if anyone has them. I did have one that was submitted already that is for Jane, Francis, and Susan if you wanted to jump in. The question is, can you discuss communication tips for women that might have religious objections to family planning but are concerned for their reproductive health, especially women who have been sexually assaulted? So again, can you discuss communication tips for women that might have religious objections to family planning, but especially those who have been sexually assaulted?
Well, from the family planning perspective, we provide services to everyone regardless. And if a woman comes to us and says that she liked the sexually transmitted infection testing, but she doesn't want the emergency contraception, that's okay. And our nurses and nurse practitioners, and really at this point every staff member, is great at explaining the mechanism of the emergency contraception that we dispense through our program. What we use is Plan B one-step or a generic equivalent, and so we're incredibly good at explaining how that works and giving that information to any patient so that she can choose whether or not that aligns with her beliefs and values. And if it does, great. We'll provide the medication if she wants it. If it doesn't, we understand, and that's her choice. That's her place in the world, and that's fine.
And I think from the perspective of advocacy, if we're talking directly about a survivor herself who has religious objections, I think that's a conversation that we just sit and have with them and help them figure out for their own person what's going to be the best avenue. So if they, whatever their belief is in that, we just kind of listen to that and help them try to figure out what they want to do with that. If there's a religious objection from community members who don't like the way we advocate for women that are sexual assault survivors. We just kind of talk about how it's not our belief, it's not our choice, it has nothing to do with us. What we do is get the help that people want when they come to us. So they come to us with whatever beliefs they hold, and we try to find the best avenue for them, regardless of any of our personal beliefs. It's all about them, not about us.
All right. Great, thank you so much for sharing. Again, if you have any questions, you can feel free to raise your hand like we practiced before, and we can unmute you, or you can put that in. I got a thank you with an exclamation point, actually 3 exclamation points from the person who submitted that question. While we're waiting for possible other comments or questions to come in, I was curious to see that since you started this initiative, Jane and Frances, I'm guessing that you've been exposed more to another field than you may have been previously. So if you worked in sexual assault, maybe you're learning more about the family planning and vice versa. And I was wondering if there are any lessons that you've learned or any things that you came across that were maybe a new experience for you that the rest of us might benefit from hearing about.
I can say from our perspective, actually what's really nice about this partnership is that you can trust the issues around health provisions are going to be provided by someone who has that expertise. Because, you know, advocates are often feeling like they have to dabble in the expertise and be an expert on everything because it seems that other people aren't. You know, addressing victims the way they should be. So a partnership is really nice because we can turn over that concern and know that when they go to family planning, they're going to get the health services that they need. So when you have a partnership and you can completely trust that partner, it alleviates your feeling that you have to learn everything about health services. So I think, you know, what have we learned is that we have a great partnership and we can trust that the clients and the patients are going to be served with the best respect and dignity because this is an agency we trust.
I would agree that the partnership piece and the trust piece has been the biggest, most beneficial takeaway. I think one of the things that was surprising for me was our staff is incredible at allowing patients to, in terms of their reproductive health and their reproductive choices and the care that we provide, our staff is incredible at letting the patient be self-directed. In that context, we sometimes tend to be a little bit maternal, and so when we started talking about rape, sexual assault, domestic violence, translating that self-directedness across for the patient and having them, you know, and having them accept that it's okay for a patient to say no or to do something other than whatever is in our heads as individuals is the best thing. It was fascinating. It was fascinating for me, and to be honest, it's a huge credit to our staff because they really want to see people in the best situations possible, and they really did come quite a long way to recognizing that the best outcome possible is really, in this instance as well as in reproductive health, determined by the individual. And a lot of times, you know, we had to do, and with our staff, still to this day, we end up doing a lot of reassurance that it's okay if the patient says no. It's okay if the patient says maybe, or if the patient says, I'm going to do this but not that. You know, really reinforcing that they are still, you know, that they still really are the everyday heroes that they are and that they want to be. You know, so I think that was an interesting thing to learn and see our professionals sort of struggle with. But ultimately, at the end of the day, you know, they also don't. When someone tells them that they've been a victim or survivor of domestic violence or sexual assault, our staff doesn't have to stress about the quality of services that they are going to receive when they're referred to the women's community or any of our other partners in this area, and that's been huge.
Awesome, thank you. We did have another question come in that should have gone out to the whole audience, but I'll read it out. It says, for Francis, how might a sexual assault advocacy agency best make the first move to build a bridge with public health? Many of our counties don't have specific family planning agencies.
So if you have, so Family Planning Health Services is a member of the Wisconsin Family Planning and Reproductive Health Association. If you have a local provider and you're not quite sure, you can send me an email and I can help you get connected through that network. I always say the best way to start with anything is a phone call, and my background prior to coming to Family Planning Health Services was in a very different type of advocacy work, and what I found was most effective often was show and tell. So even if you've been in your agency for, or in your community for 25 years, the people at the health department are the same people that have been there the whole time. There's nothing quite as effective for getting people out of their shells as calling up and saying, hey, would you like to come over and take a tour? I do this all the time as outreach coordinator. Anytime anybody wants to come through our facility, they contact me, I set it up, and we go through and we talk about what's in the building. Who are we? What do we do? Who do we serve? What does it mean? Don't be afraid to pick up the phone. The worst thing you can't, if you're at zero, you can't end up in a worse situation. So it's worth the chance.
Great, thank you, Francis. Again, if there's any other questions, feel free. We've got maybe about 10 minutes left on the call, and I know everyone really despises ending early if needed. I did have a question that came from our table here, actually not from me, asking about evaluation of the program and what outcomes you've been looking at through this collaborative, if you've had any evaluation, and specifically in that process, how you've really been able to address confidentiality through that process as well.
So to date, evaluation has been primarily on a case-by-case basis. We've had some preliminary conversations about how that changes moving forward with our new endeavors. But, typically on the case-by-case basis, I might get a call from the women's community that says, hey, I had someone call, and these are the things that happened. The call went to voicemail. We got a call back. An hour later, the person who answered or who called us back didn't know what the women's community was and didn't know that we had services on site, and then tried to call the prescription to a pharmacy. That's sort of a worst case scenario for our partnership, but. So I know that a call came in. So I can go back to our records and see who was working that day around that time, who might have handled that call. And then I can go back and I can address, what the training issues might have been. So we've gotten really good at giving each other sort of the scenario of what happened and asking the question of why did it happen that way, and if it's something that, because a couple of times we've identified, oh, this is a system problem, and then we talk about how we're going to address that going forward to change the system to meet the need better. So so that's kind of, does that answer the question well enough? Jane, did you have anything to add there?
Well, I did actually. I think that the other issue that people are always concerned in partnerships is somehow confidentiality gets lost, and it just doesn't, because both of our agencies are so bound by that. Outside of when someone comes to your door and they give you your name, now you know who they are. But outside of that, there's no other information that is exchanged. So when someone comes in for EZ, We have them fill out the paperwork that's sent off, a phone call is made, and beyond that, getting permission to hand them the pack that has a pill in it. There is no other information that the advocates receive about that person. And outside of when that person leaves our door, there's no other information outside of that they came here for the EC that the family planning is going to get from us. So our confidentiality is still very much in place. The only things that are shared is they sign a form that they know we're going to fax over this information and talk to a nurse to get approval to give them the pill, but beyond that there is nothing else that's shared.
Awesome. Thanks for clarifying that. As we wrap up, I don't have any more questions here at the table or on the chat. Were there any last comments, Jane, Francis, Susan, that you would want to share with everyone before we wrap up?
I do just have one thing, if anybody, I just am seeing the email that is listed on this last slide. Actually, there's no apostrophe in my email address. If for some reason someone wanted to contact me, there's no apostrophe.
Mm-hmm. Oh, thank you for clarifying. All right. Well, that being said, I just want to say again, thank you so much to the women's community, Family Planning Health Services, Department of Health, and all of you for taking the time to join in. We're really excited that folks are a part of this. Stay tuned and check out your email for that upcoming May webinar. And in the next 24 hours, we'll be sending you a follow-up email along with the slides and a short follow-up survey that we'll use to inform future stuff. So thanks again and have a great week.